Thanks very much for inviting me. I appreciate the opportunity to talk with you all about CCDS and seizures. I'm going to talk about seizures and epilepsy in a very general sense, talk about some of the treatments for seizures, focus on what we do know about seizures and CCDS, but overall, we don't know very much. And I'm going to end with kind of a plea to participate in research, especially if you're a family who has a child or any family member with someone who has any of the cerebral creatine deficiencies. So neurologists think about seizures in many different ways. There's two main classifications. We think of focal seizures and generalized seizures, and that has to do with where the seizure starts in the brain. A seizure is an abnormal coordinated electrical discharge. In some people, some of their seizures start in just one small spot, and then in other people or in other situations, the seizure might just start all over the brain all at once. So a focal seizure that starts in just one part of the brain, that part of the brain is what's affected, and so then the symptoms of the seizure have to do with what that part of the brain does. So I'm going to show you a picture or a video. This boy's having a focal seizure. What you'll see is his left face is twitching. Whoops. Sorry. So we can see his left face twitching. That implies that the seizure is starting the right side of his brain. Now, if the seizure was starting in the left side, in the other side of the brain, then the other face would be twitching. In addition, focal seizures can have what are called automatisms or automatic type behaviors, lip smacking, like, or fumbling in a stereotypical way, wiping the nose in a stereotypical way. A focal seizure can last a few minutes, and sometimes up to 20 or 30 minutes. The person can often understand what's going on during the seizure. They can talk to you a little bit, but they're not totally normal. It's very, very common for the child to be very tired or exhausted after a seizure. Although focal seizures, each individual focal seizure can be different, a particular person, when they have focal seizures, tends to have the exact same seizure over and over. So that's a focal seizure. That's one example of a focal seizure. Generalized seizures, the electrical discharge that is the seizure starts all over the brain all at once and causes symptoms all over the body all at once. And so this is a little boy having a generalized seizure. And you can see as in both sides of his body are jerking in rhythmic kind of contractions. His face is twitching. There can be drooling. There can be cyanosis, which is the medical word for turning blue around, especially on the mouth or the face. Convulsive seizures often last seconds to minutes, 4 or 5 minutes. Sometimes people have prolonged convulsive seizures that can last 10 or 20 minutes. In a typical convulsive seizure, there's an onset of the seizure tends to ramp up, and then the seizure goes for a certain amount of time, and then slows down and stops, and then the person is tired afterwards. So that's a typical generalized convulsive seizure. There are other kinds of generalized seizures. There's atonic, or what people often call drop seizures. So this is a lightning-fast loss of tone, and the person just falls typically forward. They don't have time to protect their face. They often end up with terrible facial injuries, and they don't lose consciousness. They're normal right after, and that can be a very difficult type of seizure to have because of the risk of injury, and it's a hard one to stop as well. Tonic seizures are where the whole body just stiffens. Some children have tonic stiffening of their arms or their upper body for a few seconds or minutes, and then it stops. A myoclonic seizure is a fast jerk of the body, not so much a drop seizure where someone loses tone, but a sudden lightning-fast jerk. And then we already heard about absence seizures. So this is a typical absence seizure that's being triggered by hyperventilation, which triggers absence seizures. So he's blowing on the whatever that is, and then all of a sudden he has what I would call a behavioral arrest. He stops doing what he's doing. He has some eye rolling upward, eyes flutter a little bit, and then he immediately gets back to normal and just starts doing what he does again. Like Dr. DeGrasse says, the EEG during an absence seizure shows this typical 3 cycle per second or 3 hertz spike wave discharge during the EEG. And we'll talk a little bit about the importance of EEGs in helping make a diagnosis. But that is a typical absence seizure. And then finally, there's a seizure type that's not well reported or not commonly reported in cerebral creatine deficiencies called infantile spasms. So this is a seizure type that typically only happens in infancy. And the seizures is that kind of quick, almost looks like an abdominal crunch where the infant's legs come up. Sometimes the arms come in and the head ducks, the eyes roll up. Sometimes the arms can actually go out and the baby can extend instead of flex forward. These seizures typically happen in clusters, either right when the child is falling asleep or right when they're waking up, and then they're usually very unhappy afterwards. as I said before, this hasn't been very commonly reported at all in cerebral creatine deficiencies, but it also may be that we neurologists, pediatricians, geneticists aren't as good at testing children with infantile spasms for cerebral creatine deficiency as we could be. So I think that's another point that that has been made already, that we should be increasing awareness and trying to get better diagnosis. So why is it useful to know the seizure type? So especially in focal seizures, it can tell us where in the brain the seizure might be starting, and that may predict which anticonvulsants can be helpful. There are certain anticonvulsants or medications used for seizures that are good for certain types of seizures, and some that actually make certain types of seizures worse. So knowing what types of seizures the child has can really help us make the right anticonvulsant recommendations. And also it can facilitate communication with your neurologist. So some seizures, like a convulsive seizure, that's something we really try hard to stop. But an absence seizure, a child can have 50 of those a day. And if someone calls me and says, my child had 50 seizures today, my first thought is, oh my goodness, go to the emergency room right away. But if really they just meant 50 absence seizures, then that's something they don't have to go to the emergency room for. So making sure we all are talking about the same types of seizures is helpful for patient care, and then also for patient registries. And so especially now that social media is so helpful to identifying groups of people and families whose children have these rare syndromes, we're getting more and more information from groups like this about seizure types. And if we can all agree on what we're calling certain seizure types, that's going to help us, neurologists and other scientists, define better treatments. EEGs can help us define what kinds of seizures people are having. And EEG is where they glue all these wire leads onto the child's head and measure the electrical activity of the brain. Often, almost always, not always, but almost always, a person who has seizures has an abnormal EEG even when they're not having a seizure. And so it can show either the focal discharges that are always there or sometimes generalized discharges, and that helps us know what kind of seizures the person's having. A seizure syndrome is defined by the type of seizure the person's having and their EEG. So for instance, absence seizures can be diagnosed with the combination of how the seizure looks on the person and how it shows on the EEG. And then in many cases, children with seizures or adults with seizures, we know they have some seizures, but then they start doing something new that is like a staring spell, and we don't know if it's a seizure or not. And in many cases, we can do what's called ambulatory EEG or prolonged EEG. This is where the leads get hooked up for days at a time, maybe 2 or 3 days. Either the patient stays in the hospital the whole time, or sometimes there are companies that can come out to the house and hook up the EEG leads, and we can just monitor for 3 or 4 days if the child can tolerate it that long. And then see if they have one of the spells that they were wondering if it's a seizure or not. We can just see on the EEG if it's a seizure. So EEGs can be very helpful in diagnosing seizures. Seizures are very common among children. About 1% of children have at least one seizure during childhood. Epilepsy is when you've had 2 or more unprovoked seizures. So a provoked seizure is if you fall off a horse and hit your head and then have a seizure. We call that provoked. An unprovoked seizure would be a seizure out of the blue. Or if so, 2 or more of those is diagnosed as epilepsy. Or if the child's had one seizure but has a pretty high chance, maybe greater than 60% of having another seizure, basically if their EEG shows a seizure tendency. We're pretty sure they have a high tendency to have seizures. For children with epilepsy, the first anticonvulsant we try works in most but not all cases. If 2 or more anticonvulsants, the right anticonvulsants at the right doses, have not stopped the seizures, we call that refractory epilepsy, or sometimes we call it drug-resistant epilepsy. This happens to about 30% of all people with epilepsy. That is that the medication, 2 or more medications have not worked for their seizures. Another important thing in epilepsy to think about is something called sudden unexpected death in epilepsy. People call this SUDEP, that's the abbreviation. And this is when a person who has epilepsy suddenly dies, not from a seizure, but for no apparent reason. So people with epilepsy have a slightly higher chance of suddenly dying than people without epilepsy. It turns out that most people with epilepsy who die of something else, like a heart attack or an accident. 30% of the deaths in people with epilepsy are actually related to a seizure, for instance, having a seizure in a swimming pool and drowning. And then a very, very small number of people with epilepsy just have sudden death for no known reason. The rates in children is much lower than in adults. The risk factors in children probably have more to do with the epilepsy syndrome that they have. So for instance, Dravet syndrome, other known epilepsy syndromes have a higher risk of SUDEP than other children with epilepsy. And that's probably related to the cause of their epilepsy, also may cause problems with their heart or how their heart conducts electricity, similar to how their brain conducts electricity in an abnormal way. In cerebral creatine deficiency, we don't have a lot of information. These are from studies, obviously within the past 10 to 20 years. And so we don't know overall all these numbers, but it looks like most children with GAMP deficiency have seizures. The onset is usually in young childhood. They can have various kinds of seizures, and 45% are drug resistant. Creatine transporter deficiency, people with this have a lower chance of having seizures, and maybe the onset is a little bit older, and they also can have many different kinds of seizures. And in AGAT deficiency, it seems to be much less, although of course there are many fewer patients, and so we don't really know as much about that. So we have many, many questions about seizures in cerebral creatine deficiency syndromes, as well as any other syndrome. Over time, do seizures tend to get better? Do they get worse? How common is SUDEP? What can we do to try to prevent that? And then, as we're finding out, mainly through social media, there are certain medications that can work better in certain seizure syndromes than in others. So, for instance, a certain seizure syndrome may turn out that a particular medication just never works in that or makes the seizures worse. And this is information that neurologists are finding out through contact with families who are in contact with other families through Facebook and Twitter and things like that. So moving on to anticonvulsants. So we have a whole range of different medications we can use to try to stop seizures. In general, neurologists look at the seizure type the person is having, try to pick a medication that they think will work for that seizure type, and then not cause bad side effects. We typically start at a low dose, then slowly increase the dose until either the seizures stop, there are horrible side effects that make it so we have to stop the medication, or we just get to a maximum dose. And then if the first medication doesn't work, we typically add another medication, taper that one up as needed, and then if that doesn't work, we often add another medication. I think most people try to get off medications that aren't working, although as many of you with children with seizures know, it's often difficult to take away medications as well. Something to think about in GAMP deficiency in terms of choosing anticonvulsants is one particular medication, valproate, can increase CSF glycine. And so glycine is something that we sometimes try to decrease in GAMP deficiency because it can lead to the accumulation of GAA. So we don't know for sure, no one's ever done an actual study to find out whether or not valproate causes an increase in GAA that causes problems, but it's just something to think about, and all of us should be thinking, all of us neurologists should, and families should be thinking about picking the absolute right medication for their child. Probably many of you have heard about CBD oil for epilepsy. This is relatively new, and it's certainly a widely publicized topic. There are, of course, no studies in children with cerebral creatine deficiency. It's best studied in children with a different set of syndromes, the Dravet syndrome, Lennox-Gastaut syndrome. I believe there's studies in tuberous sclerosis. In Dravet and Lennox-Gastaut, it seems like it decreases seizures. The studies were with relatively few number of patients compared to studies that we do in other seizure medications, and it was a relatively short study compared to the longer-term studies that last years that we've done in other patients for other anticonvulsants. Typical side effects are increased sleepiness, actually decreased appetite. In one of the initial studies, there were 2 cases of SUDEP in children who were given this medication through a study, and the study researchers felt that the SUDEP was unrelated to the CBD oil. CBD oil may increase liver enzymes, especially if the child's also taking valproate. And then there is a known interaction with another seizure medication called clobazam. It tends to make the clobazam levels go up, and so if someone's taking CBD oil and clobazam, you'd probably want to have to decrease their level, their dose of clobazam, so to not get side effects from it. And I give you all this information just to point out that CBD oil is probably going to be similar to all the other anticonvulsants. There's probably going to be patients for whom it works, and may reduce or even stop seizures possibly. It's probably going to have similar side effects to other seizure medications and may have medication-medication interactions. And so I think a lot of people feel that since it's a natural or maybe a natural product that it's not going to possibly have side effects, but I think we should all be aware that it definitely can have side effects, just like everything else that works in the brain. There are non-pharmacologic or non-medication treatments for seizures. There are devices, the vagal nerve stimulators, a device that can be implanted. The battery gets implanted in the chest, and wires go to the vagus nerve in the neck and send off a signal up into the brain, and this can decrease seizures. Using a magnet over the device to give an extra dose of electrical stimulation can stop a seizure, and so that can be very helpful for children who are having long seizures. One of the main disadvantages of a vagal nerve stimulator is once it's in place, you can't have an MRI of your thorax or kind of your chest just because that metal's implanted. You can have an MRI of your brain, but not of your thorax. And this can be helpful. There are other implantable devices. There's a responsive neurostimulator that can be implanted in the brain for people who have focal seizures, and then the stimulator can detect when a seizure is about to happen and give an extra stimulation right in that spot and maybe stop seizures. So these are options that are not medications. There's the ketogenic diet, which maybe many of you have heard about. It's a high-fat, relatively high-protein, low-carbohydrate diet. This is not the paleo diet that you can get from a magazine. You would definitely do this through a dietitian, and may not be a very good choice for children who are on a protein-restricted diet anyway, but it can help with seizures. And then there's epilepsy surgery. So especially for certain seizure types or seizures that start in just one part of the brain, surgery can decrease seizures, although the effect seems to be best early on, and then later on maybe seizures come back. So that's kind of the nutshell of where we are with seizures and the little bit we know about seizures and cerebral creatine deficiency. On the horizon, pharmacogenomics is a relatively new option that is coming on the horizon. It's not quite available yet. So this is looking at how an individual person metabolizes medications. And so if I metabolize certain medication, if it can be predicted that I might metabolize a medication really fast, then we might know that my dose might need to be higher in order to work. Conversely, if I'm a slow metabolizer, maybe I should start at a super low dose. And that can help us pick certain medications correctly and dose them correctly for an individual patient. And then also there is some testing that's available that can in very restricted situations, determine the risk of someone having an allergic reaction to a medication. Currently, for all the anticonvulsants, there's only one validated test for any of these things, and so this is for people from certain parts of Asia. As you all know, Asia is very large, not for all Asian people, but for certain parts of Asia, it can tell whether or not they have a higher chance of being allergic to a medication called carbamazepine. The other medications that we have, that there are commercially available tests, but they haven't been validated. So we might be able to find out some information about your genes that are used to metabolize these medications, but we don't really know how that translates into practical work, practical decision making. And then to end, how we all can help is participating in research, signing up for patient registries, giving your data. I would encourage you, if you feel at all comfortable, to give your data to these registries so that we can, or your child's data, so that we can collect it all together to find out what rare disorders, or maybe not so rare disorders, what they're really like for people and what works in terms of treating them. And then share your observations with your doctors. Oops, sorry. And so in summary, we have many, many unanswered questions about seizures in general, and especially seizures in cerebral creatine deficiencies. Participation in research is the best way that all of us are going to be able to find any answers. And networking with other families and sharing your observations with your doctors, even before a research study is published, can be really helpful. Thank you.